Now, another important thing that we have now to talk about, instead of death we spent so much time on, which included necrosis and apoptosis, we're going to make the transition that's much more exciting, that's reversible, and that is cellular adaptations. So basically, it's a cell that's able to try to adapt first before dying because of the stress or injurious agent that's now led to this change in the biochemical and molecular milieu of the cell that's being affected. Now, the thing that's important clinically and in any disease process, if you're able to remove the insult or stress, it's potentially what? Reversible. Remember, death, no matter what you call it, apoptosis or necrosis, is irreversible. Now, some of these cellular adaptations involve the word plasia as the stem. So what does plasia equal? It means growth. And so when we talk about growth, this metaplastic cells can now, because if you have cells dividing and they're constantly being stimulated to divide, what's going to happen as a function of time is that you acquire mutations, and if you have mutations, you can now lead to a genetic disease we call neoplasia. So at that point, neoplasia is irreversible. So what are the examples of this? Metaplasia, for example, hyperplasia, where you're going to have increase. The diagram that's illustrated here is showing you the various types of cellular adaptations that one sees in response to cells that are being affected by some type of stress or stimulus. So one we're going to talk about is the cells become smaller. We call that what? Atrophy. If you have increased number of cells, we call that hyperplasia. If we have loss of size, shape, and orientation of the cells, but we have increased cell number, we call that dysplasia. And we think the classic example is HPV or human papillomavirus. Then there's some cells that are under stress will cause the stem cells, or what sometimes we call reserve cells, to go from one histologic cell type to another type. We call that metaplasia. And what's the classic example you learned about is Barrett's esophagus, when you have the stratified squamous epithelium under constant reflux that's going to now revert to what is called a simple columnar epithelium or glandular epithelium, because glands make mucus and can protect it under this new environment of acid. Sometimes you can have combinations of hypertrophy and hyperplasia at the same time. What's a classic disease process that you've learned about is asthma or chronic bronchitis, where the submucosal glands in both asthma and chronic bronchitis become increased number of cells as well as hypertrophy. And then hypertrophy, what do people go to the gym for? Is to hypertrophy your skeletal muscle, get buffed, or they also try to atrophy what cells is the adipocytes. And if they don't go to the gym, the other process will reverse itself. So let's talk about atrophy. Basically, we have decreased cell size because typically we think of it can't make some type of organelles or structural proteins, like in muscle, for example. And when we talk about atrophy, if you have various conditions going on that makes the organ smaller, it may not be because of decreased cell size, it may be decreased cell number, and or another important process can occur in organs that make it smaller is scarring. Because remember, in fibrosis, what do you have as myofibroblasts? Myofibroblasts have the ability to contract the tissue down, and so it can make the organ smaller. What's a classic example is hypertension and its effect on the kidney. You get these very small kidneys. Normal kidneys are about, in adults, are about 12 to 14 centimeters in length, and some kidneys I've seen done at autopsy are only 3 centimeters or an inch tall. And obviously the patient is in chronic renal failure and is on dialysis or will receive a renal transplant. So what organ system that's critical to it in terms of structural proteins you constantly see atrophy is muscle. And so if you don't use it, you lose it. Immobilization, you think of people that are basically in a hospital or in a wheelchair, paralyzed, they're going to get atrophy. So if you don't use it, you're going to have atrophy. Or, for example, the classic example, somebody gets a cast on their leg or their arm. They don't use it for 6 months, and once you take it off, they look at their arms and say, my God, one arm is smaller than the other. But never fear. Once you start using it again, it'll go back to its normal state. That's why it's clinically important to realize it's reversible. Another important thing that can lead the cells to atrophy is the lack of oxygen. ischemia. So under chronic hypoxic states, what's going to happen to the cells? They can't synthesize proteins, can't produce enough organelles. So what's going to happen to the cell tissues? They're going to get smaller. What's a classic example of this is in a diabetic where they have microvascular disease, where the skin of the lower extremities become thinner and they have breakdown and they're more likely to produce wounds or ulcers that never heal. Another important thing is they will reduce atrophy is the lack of hormones. Remember, hormones have not only a myogenic effect, but they have a tropic effect where they'll affect the cell size. So if you lose basically, for example, cortisol, what's going to happen to tissues is that they're going to get smaller. And so this becomes important. Another thing that also affects especially skeletal muscle is the integrity of the synthesis of structural proteins is neuronal stimulation. So when you have polio, destroying the alpha motor neurons, or if you have a laceration to a peripheral nerve which has motor component, that innervation that's now lost will lead to atrophy of that tissue that's being innervated. Another important thing is malnutrition. Obviously, in order to make macromolecules, remember macromolecules is not just synthesis, but degradation occurring at the same time. So if you're not able to synthesize, your degradation will take a greater effect. So what's going to happen? The cells become smaller. And that's why people go on diets, get those adipocytes smaller, but they get frustrated because they go back to their old ways of lack of exercise or eating too much caloric intake or taking too much calories. They become hypertrophied. Aging, by far, is the most common cause of atrophy. If you ask your grandparents what their height is today versus when they were 20 years old, they'll tell you they're smaller. So when you're studying for the U.S. military, you're going through apoptosis and shrinking. So what happens is a function of time as tissues go through the process, especially highly metabolic organs, like the hepatocytes as well as the myocardial cells. They can acquire not only smaller cells, but lipofuscin. We'll talk about this in a moment, where you get increased basically phospholipid protein complexes, and we call this lipofuscin, a golden brown pigment. And basically what you're going to see is decreased cellular components. They're going to be the cell will go through the process of autophagy, or autophagosomes will form, where you're self-digesting yourself, and so obviously if you have decreased organelles, the cell size will become smaller. The opposite of atrophy is hypertrophy. So what's going to happen in this case is you're going to increase the synthesis of structural proteins and or organelles. So obviously the cell has to get bigger. So what are the causes for this? Obviously, increased mechanical demand, like that's why you go to the gym. You stretch the muscle as well as other hormones like in skeletal muscle, like endothelin-1, for example. You'll stimulate structural proteins and you'll increase the cell size. We call this hypertrophy. Obviously, the organ will get bigger because of the hypertrophied mass. So increased mechanical demand is an important way, especially on cells that require a reaction to that when you think of muscle. So when you think of physiologic, it could be weightlifters, or if you're a runner or doing a lot of aerobic exercise, what are you going to stimulate is physiologic hypertrophy of your heart. Now people will say, well, how is that different than hypertension, where you have a pathologic change? And in this case, what happens is you increase the demand, but it's short-lived. And then you have a time to go back to a normal metabolic state. When you have hypertension, where you have an elevated blood pressure, where there's constant demand 24 hours a day, 7 days a week, what you're doing is going beyond the physiologic state of that organ. In this case, the muscle becomes so hypertrophied that it can, in the case of hypertension of the arterial type, what part of the heart is being affected is left ventricular myocardium. So now the heart muscle becomes thicker and thicker. But when you have hypertrophied muscle, and you've got to keep it, or any hypertrophied tissue, what happens to it? Oxygen and nutrient demand must be maintained. It's higher than at the normal state. So obviously, if you have somebody who has hypertrophy of the cardiac muscle, its oxygen nutrient demand is elevated. Therefore, it's prone to ischemia. It can lead to infarction, or because it's a conduction system, it can also lead to arrhythmia. So when you have patients who have hypertensive heart disease, you have to worry about it's arrhythmogenic, and they can die at any moment in their sleep, or they can have an acute infarct. And if they have coronary artery disease superimposed, or if they have anemia where you can't deliver oxygen, you are in trouble as a patient, and they can lead to damage. Versus the physiologic state of hypertrophy, when you're an athlete, your heart will get bigger, but it's going to become more efficient. What happens to your stroke volume? It increases. What happens to your heart rate when you become an athlete? It becomes lower. And so therefore, it becomes less of a problem in terms of becoming arrhythmia and ischemogenic. So it's good to exercise. You don't have to worry about getting a heart attack if you're an athlete. It's physiologic hypertrophy versus pathologic in the case of hypertension. By the way, what's the definition of hypertension without using numbers? I'll let you think out there. Is hypertension is defined as an elevated blood pressure that leads to end organ damage. And that's the critical thing you should always think about when we get to hypertension. Remember, 1 out of every 5 or 6 people in the United States will develop hypertension during their lifetime. So when you're studying for the USMLE, exercise. Don't take the elevator, take the stairs, or walk, or bicycle, doesn't matter, but it's important to keep the cardiovascular system well tuned. So endocrine stimulation. If you have too much endocrine, it can lead to, remember, it's mitogenic as well as increased structural proteins. What's a classic example of this is when you have too much ACTH. What's going to do to the cortex of the adrenal gland is going to make it thicker or larger because it's a tropic effect on the cortical cells that make up the layers of the layer of the cortex of the adrenal gland. Remember what are the 3 layers? It's going to be the glomerulosa, fasciculata, and reticularis. What is made in the glomerulosa layer? Remember, it's mineralocorticoids like aldosterone and cortisol in the fasciculata. And then when you think about the reticularis, it's androgens. So we think of other things like puberty. What happens? Things grow, breast buds, both males and females. What happens to estrogen? What does it do to the myometrium? It doesn't cause hyperplasia. This is important. In the gravid uterus, it causes hypertrophy because when a woman actually delivers, what happens to the size of the uterus postpartum? It goes back to its normal state because it's reversible. And then what happens to women that stop breastfeeding, or if they don't breastfeed, what happens to the size of the breast? It goes through not only apoptosis, but it's going to go through atrophy. But remember that you're going to get hypertrophy and hyperplasia in the breast because of the stimulation of estrogen and progesterone. So when we talk about hypertrophy, it's mediated by, again, growth factors, cytokines, and in the case of muscle, you think of stretch. And then what's going to happen at these various stimuli are going to trigger at the DNA level the increased transcriptional activity of genes that are important for structural proteins that are now going to make the cell bigger. And so you can, obviously, as I pointed out, you can have hypertrophy and hyperplasia together at the same time. So when we talk about hyperplasia, we're talking about increased cell numbers in a tissue or organ, and there are various things that can obviously initiate this process. But some cells cannot go through hyperplasia because they have a limited capacity to divide. We'll talk about this when we get to tissue repair, when we talk about regenerative capacities. So physiologic causes of hyperplasia, you think of what happens if you take out part of your liver. The hepatocytes, even though they're differentiated, they can now proliferate and reconstitute the liver. And this stops based on the metabolic needs of the patient. What are the 2 main functions of the liver in broad categories to think about? What's the function of the liver? It's synthetic activity and detoxification. And that's how you think of the liver, and those will be compensated for once the liver regains its normal state prior to the hepatectomy or partial hepatectomy. Obviously, what's going to happen during puberty, you're going to induce hormones, and it's going to cause various cells to go through the process of hyperplasia, like breast, both males and females. Because what's missing in male breasts compared to females is the lobular units. That's why in the middle of the night the wife says, "Dear, it's your turn to breastfeed." He can't because he may want to in spirit. He cannot produce milk. because that's the difference between men and women, is the lack of lobular units. Can men get breast cancer? Yes, because most majority of breast cancers come from what? Ducts. So it's important to know what is normal. Will they ever show you a picture of a male versus a female breast on the USMLE? No, but you should know this clinically. It's very important. Obviously, antigens that are exposed to the immune system will lead to the release of various cytokines, will stimulate the myogenic effect on lymphoid cells, T and B cells, that will lead to lymph node enlargement. We call that lymphadenopathy. And then pathologic causes, when you have unopposed estrogen effect on the endometrium, you get hyperplasia, and the problem with hyperplasia in this case, it can go on to neoplasia because you're acquiring mutations. And so you think of endometrial hyperplasia increasing the likelihood of endometrial cancer, or if you have ductal hyperplasia in the breast, for example, increase the likelihood of breast cancer or ductal carcinoma. Now, prostatic hyperplasia does not increase the risk for prostate cancer, but it's a common feature that finds in males that it become over the age of 60. And as you get older, by the time you're 80, about 80% of 80-year-olds have some form of hyperplasia. The ducts, ducts, but mostly glands and stromal cells. And what are the stromal cells that make up the prostate? Are fibroblasts and smooth muscle cells. So it's mediated, again, hyperplasia by growth factors, cytokines, and other stimuli that will have an increased propensity of cells entering the cell cycle and increasing the cell number, like growth-promoting genes. And obviously, if you're going to cause cells to divide, they've got to go through DNA synthesis as well as cell division to increase the number. Another important cell adaptation is called metaplasia. And what is that defined as? Is a reversible change that takes one epithelium or mesenchymal cell and changes it to a different type based on the environment in which the cells have to be exposed to by some type of increased demand or irritation or stress on the cells that now allow this process to take place. And basically, it's trying to make it better, but not always. Depending upon, if you change that cell type, you're also going to alter that function of that organ, and now you're vulnerable to other things that you hadn't realized, and the cells don't know this. They're just trying to adapt based on what's going on. Is, for example, when you think of the ciliated pseudostratified column epithelium of the respiratory tract, whether it's the upper or lower, if that cilia or mucociliary clearance is now changed to squamous metaplasia, like in chronic bronchitis, what happens to the mucociliary clearance? It's now diminished because you don't have the ciliated cells anymore, so now you're prone to infections. So when we get to the respiratory tract, any disease process that alters that mucociliary process, you're prone to infections. That's why chronic bronchitis or chronic bronchitis patients are going to be more prone to developing infections because of this. Another example of this that one can see is in Barrett's esophagus, where you have basically you're changing the stratified squamous epithelium to a columnar epithelium, and you say that's fine. But the problem is those proliferating glandular cells can increase the mutation rate, and you have to worry about adenocarcinoma arising in Barrett's esophagus. So there are consequences that one has to remember that can be related to metaplasia. And so when we talk about what are called reserve cells or stem cells, remember what's the definition of a stem cell? It is a cell that's self-renewing and is able to basically differentiate into other cell types. And that's how you think of stem cells. Depending upon where you are in the differentiated state, where you're a total potential cell, we can differentiate in many lineages versus to only one lineage, you have a different degree of capacity to regenerate to that particular cell type. And so basically these stem cells or reserve cells are important in that they are able to differentiate into the type of cell that's required based on the stress that's going to dictate this process. Another important term, and some people will initiate and say this is not an adaptive response, but there's a reflection of the disease process leading to neoplasia, is dysplasia. And again, plasia means growth. So when we talk about dysplasia, it's a proliferation of cells, but they've lost their size, shape, and orientation to the normal maturation of that normal cell type. And what's the classic one that they love to ask about as a reflection of dysplasia, as an example, is cervical dysplasia due to chemical carcinogen due to cigarette smoke or human papillomavirus, whether it's, for example, 6, 11, 18, 16, 18, 31, 33. There's a whole list of these. And so remember, an important point you should recall that dysplasia is reversible. It does not equal cancer. Can it go on to neoplasia? Yes. And therefore, neoplasia is considered irreversible because you've acquired enough genetic changes that you cannot go back to the normal state. What are examples? As I pointed out, cervical dysplasia. You can get dysplastic keratinocytes in a pre-cancerous lesion to squamous cell carcinoma. What do we call that? Actinic, which means what? Solar rays. Keratosis means proliferation of the squamous cells in response to this. And the most common cause of this is obviously UV radiation. Oral leukoplakia, you have proliferation. What does leuko mean? White, because you get a proliferation of squamous cells. And you get, what's a classic example of this is hairy leukoplakia due to Epstein-Barr virus, and you see in AIDS patients. It can lead to squamous cell carcinoma.